Good morning, welcome. I'm John Dixon, I'm from Melbourne, Australia, and this meeting has been sponsored by Radiant Health, so they've sponsored me to come and talk about obesity today. Now, what's my background? My background is actually in rural general practice in Australia, except for the last 20 years I've done nothing but full-time research into obesity, what problems it causes, how we treat it, and all sorts of aspects of this epidemic. I've written hundreds of papers, so you'll see plenty out there, and I'll refer to a few today. Now, my focus today is on why you have to go beyond lifestyle. And I shouldn't have to go much further because there's no other serious chronic disease where you have to go beyond lifestyle in management. Things like diabetes, hypertension, dyslipidemia, cancer. We do it for every other chronic disease. Why is this one different? Why are we talking about this? Because we have a catastrophic problem. If you look at those two figures up the top, we've got the number of men and women around the globe who are suffering from obesity. That's the whole spectrum of obesity, BMI 30 plus. And you'll see the blue, that light blue, that biggest area there is wealthy English-speaking countries. And men are on this side and women are over on your right. And if we look down the bottom there, we see severe obesity. That is a BMI over 35. And what you'll see there is there's a big difference between men and women. Women absolutely dominate severe obesity everywhere around the globe. So that's where we are. We've got a horrendous problem. We're not preventing it. We're not dealing with it very well at all. And if we look at primary care and what you guys can do, we see rather daunting results because the lifestyle that you preach and the indications that you and many of your primary care colleagues do and your allied health actually produces almost no effective weight change whatsoever. 1 to 3% weight loss at 6 months, and then out at 2 years, very, very little. And you know this, and you've seen it over and over again. So with an intensive combination of diet, exercise, and so forth, the best of us can achieve about 5%. And this is a problem, and it's even less out at 2 years. The reality is that those people who really lose weight easily and keep it off is around 1 person in 20. They have 2 advantages. One is that they have a physiology that allows them to lose weight, and the second is that they have an obsessive-compulsive personality such that they're able to stick with their behavioural change indefinitely. The other 19 out of 20 are not in that category. And I want to remind you of something really important, and that is that modest weight loss, modest sustained weight loss is incredibly powerful. We look at 5 to 10% weight loss as providing much of the benefit for anyone who's losing weight. Doesn't matter where you start, 200 kilograms, 100 kilograms, 5 to 10% weight loss makes most of the difference. 5% weight loss is the greatest prevention of diabetes that we have. 10% hardly makes any more difference. All of it's in that first bit. Many of our comorbidities, arthritis, liver disease, sleep apnea, most of the bang for the bucks is in the first 10%. We often forget that, and I find surgeons are always forgetting that because they can do so much better. But most of that, so if we can think about how many of your patients can you have a sustained 5 to 10% weight loss, that is going to make a huge difference to health. Now, sadly, but realistically, everything that's essential for life is carefully regulated. And it's carefully regulated by that thing called the brain. And I've put a slide up there that shows bariatric surgery changes after over 20 years. This is from the Swedish obese subject study. And you can see the top mark, that's the control group, and you can see 3 different bariatric surgical procedures producing sustained weight loss over 20 years. Now, why is that the case? Because those procedures are altering the regulation in the brain. There's no other way of them doing it. But if you look at that and you think, well, if I took a blood pressure tablet and it was up there and I took it for many years, it would come down and it would stay down unless you stop the tablet. exactly the same. We regulate our weight, and that's why it's so difficult to lose weight. Our default setting as an organism is to put on weight, is to maintain our weight, and particularly maintain our fat. Regulation of fat's important. A lean person has this sort of relationship between their meal size and their satiety. Satiety is that feeling you get after a meal, but it's that prolonged effect till the next meal. You have breakfast and then you feel comfortable and through to another time. This is the dose-response relationship for a lean person. This is the dose-response relationship of an obese person. And indeed, many of our obese patients never achieve actual satiety. They're always ready to eat. And I can't imagine being like that, because when I'm ready to eat, I eat. And effective treatment can do one thing. We have to slide this across to control. So any treatment I'm going to talk to you about today has that effect of giving control and changing that relationship. And any treatment that I'm going to talk to you about today needs to be used long-term to have a long-term effect. So what I'm really getting at is that if we believe that we're going to rely on lifestyle change, we need to give ourselves a reality check. We have to go above that bottom line to generate a significant weight loss and keep it off. In addition to that, all of those things that help with control are going to actually end up being lifestyle enablers. So that once a person is in control and they feel in control, they can change their lifestyle. And we see that. It's very important. So this is not a disease of lack of willpower or laziness or lack of adherence. It's a physiological problem of dysregulation in the brain that is largely set up through genes and genetic programming before a child gets the opportunity to reach the refrigerator. Now, I'm going to talk about meal replacements. Why am I talking about meal replacements? They work. A meal replacement is a commercially available product that's designed to replace real food, a real meal. It provides all the essential macronutrients, micronutrients, and it does so by reducing, at the same time as reducing excessive calories. They're often in the form of liquids, powders and bars, they are regulated, but they're not dietary supplements. They are meal replacements. There are several types of meal replacements. Some are simple meal replacements, and others have the category of very low calorie diet. You can't get very low calorie diets that aren't meal replacements, because you can't pack that into something that's less than 800 kilocalories a day. Why do I talk about meal replacements? The key thing is they work. This wonderful study by Tom Wadden and their group in Philadelphia years ago, they used a drug, sibutramine, and they just gave the people the drug. And then they had a behavioural program, then they added meal replacements. And lo and behold, those results are dramatic. And they've always criticised us for not being able to achieve those results. Without drugs, we can't achieve those results. But you can see that with drugs, we can achieve quite substantial weight loss if we add the meal replacements. Very low calorie diets are even better. Very low calorie diets produce an astounding weight loss, and there's lots of myths about very low calorie diets. One is that no one could use them. Rubbish. 80% of people can use them easily. The other one is that if you lose weight quickly, you put weight on quickly. Rubbish. That's been shown over and over again not to be the case. So if you lose weight with a very low calorie diet, you've got the opportunity to keep it off. And the strange thing about very low calorie diets is that they keep the weight off better at 5 years out. Here's this review, 4 to 5 years compared to a low energy diet. These people are maintaining a weight reduction at 4 to 5 years of 6% weight loss in that area that I've just spoken about as being critical for health benefits. You can think of the diabetes management. Now, how can a very low calorie diet keep better weight off at 5 years? You know why? Because when you learn to use a tool, you'll go back to it. If something works for you, you'll use it again. And we have many people using meal replacements and intensifying their treatment with very low-calorie diets. They work, they're effective, and the key thing about very low-calorie diets is they're low in carbohydrate, they produce ketosis, and ketosis completely suppresses hunger. And so people who are on a very low-calorie diet, after the first 3 days, are not hungry at all. Now, pharmacotherapy, another key arm of treatment. You wouldn't think of managing any other chronic disease that you manage without considering pharmacotherapy. Why is this chronic relapsing disease treated any differently? General indications for using pharmacotherapy is obesity, a BMI over 30. But in some cases with comorbidity and etc., we bring down those thresholds. Check each drug that you might be using for its indications. In addition to that, what we see is that we can individualise it, and we need to individualise for people at high risk of high ethnicity risk of increased fatness and increased risk of diabetes and other comorbidity. For instance, those of Asian ethnicity have, South Asian ethnicity have a much higher degree of diabetes and cardiovascular risk at lower BMIs. You have Pacific Islanders who have higher BMIs and seem to have slightly lower risk at those, but we have to adapt to the ethnicity of our community. These are the drugs that we have available today around the world. The ones with green stars above them are ones that you have access to today, although I gather one is not being used here at all. First of all, the one that's been around the longest over there is phentermine, really known as Duramine here. You've seen Zenical, the Orlistat, the other green one. And over here we've got Saxenda, which is a GLP-1 agonist that Novo Nordisk has now got released as a weight management tool. It's available. I gather it's been approved in New Zealand, but I understand that the company's probably not actually promoting it because it seemed to be very expensive. We've got 2 yellow stars there for things that are off-label. One is a drug called topiramate, which I'm sure you know is an anti-migraine drug and a drug for epilepsy. And the other one over here is a combination of phentermine and topiramate, which is probably our best combination to date for treating pharmacotherapy using this. We also have Contrave. You see the core ones there, naltrexone and bupropion. I'll mention those briefly. That's a combination of drugs you have available that could be put together to make the combination that works quite well. And the leucocerin there, the lowest one, is not available other than in the United States at the moment. And its place, we're a bit uncertain at the moment. So one of the most important things about treatment is, would you take treatment if it didn't work? And we now are using a stopping rule for all of our medications. Within 3 months of the full dose of any medication, we know if it works or not. The patients will tell us what effect it has on appetite, etc. So we have a rule. Once you're up to the full dose, the maximum dose, within 3 to 4 months, we can tell whether a person's responded to it. If they've responded to it, we've also got to have a reason saying, why would we stop this? Because to use a drug for hypertension, we don't use them temporarily. We use them over the long term. So Orlistat. Orlistat, you all know, it's been around for a long time. It's a lipase inhibitor. It's taken 3 times a day at 120 milligrams. It's effective for about 3 kilograms weight loss. Most studies of weight loss have people averaging about 100 kilograms, so 3 kilograms, 3% for most of the studies with an average group of men and women. So 3% weight loss. This in fact, Zendos study, which was a diabetes prevention study and a weight loss study, went over 4 years, and they achieved much better results in their placebo group, and therefore a great result in that. In other words, it's a very intensive lifestyle program. The interesting thing, which really shocked me, was that there were more people on the Zenical at the end of the 4-year study and compliant than there were in the placebo group. Now, that tells me something that you don't believe, because what you have experienced with Xenical is that feeling that it doesn't work and that people won't take it long term. Well, this study and most of others have actually shown that's rubbish. People can use it long term, do use it long term, and those that are using it successfully find it to be terrific. All of our other medications that we have today act centrally on the brain, and our patients tell us they feel in control. They feel that they don't have to eat as much to get a sense of satisfaction. They actually say, I can stop eating. For the first time, I'm normal in respect to eating. Many of your obese patients have never experienced what you, as a lean or normal weight person, normal's a bit overweight, a normal weight person experience after a meal to switch off. I feel in control. And when you feel in control, you can now enable other behavioural change. So phentermine is the one that's been around the longest. It's the most commonly used drug in Australia and in the US. In fact, it's been the most commonly used weight loss drug for decades. And it works. Its action is a sympathomimetic action on the brain, particularly the hypothalamus. It suppresses appetite. It has I'll go through the other aspects of it, but most importantly, while this is an amphetamine derivative, it has almost no serotonergic or dopaminergic effects, almost none. And there's no likelihood of a high risk of addiction. And in fact, in hundreds and hundreds of GPs in Australia, we've asked them whether they've seen addiction with this, and indeed they haven't. Only one person who works in addiction health has ever suggested that they've actually seen addiction. Now, that's not to say it can't occur, but it has to be rare. Its effect on those dopaminergic, serotonergic pathways are not there. However, people are warned about it, and people think, oh, there's a high risk. There isn't. So remember that, and of course the weight loss is, you can see there, differences at 6 months of 3.6 to 4.5 kilograms over and above placebo. So then with the lifestyle actually achieving, again, that 5 to 10%. Now the people who respond, I'll say now, the people who respond to a drug actually do better. And so if 2/3 of the people respond to your drug, that group of people are going to do well indeed. Here's one of the very early, back in the 60s, studies looking at this drug, and you can see its effect over placebo. You can convert those kilograms to percentages roughly, but you can see there that when a person responds to this drug, they're going to do very nicely indeed. There are a group of people who can't have this drug. I'm sure you're all aware of this: unstable hypertension, history of heart disease, hypothyroidism, anxiety disorders because of the nature of the alerting effects of it, history of drug and alcohol abuse, major psychiatric illness, pregnancy, breastfeeding, Mayo inhibitors, of course, a caution, and glaucoma. The more you know about this drug, the more you use it, the more comfort you'll have with it. I always start, let me say this is a rule with all obesity drugs, start low and go slow. So most adults can tolerate 30 over time. We need to evaluate side effects, evaluate effectiveness, and decide how we're going to move with this drug. But if it's very effective, it can remain effective over many years. Yes, there's an early adaptation to the sympathomimetic actions, and we'll see here, by the way, taking the dose in the morning because of its alerting effects and the sleep disturbance, which some people get, particularly in the first days or weeks when they're on this medication. Common side effects: dry mouth, usually quite tolerable. Insomnia, that fades quite quickly. Increased energy, need to reassure people that it's okay. Feeling anxious, palpitations, again, that usually abates in the first days or weeks. Constipation is common with all weight loss medications, all weight loss therapy. Less common: impotence, irritability, mood elevation. If a patient does not have side effects with this drug, and if it's very effective, why would you stop it? Briefly, topiramate, this drug that's used off-label, it shouldn't be used off-label. This is a generic drug. Multiple companies make it. It's very effective. It's one of our most effective weight loss drugs. It's just that it seems to be used only for migraine and epilepsy. The dose briefly for the dose for weight loss is exactly the same regimen as for prevention of migraine. We start low, we go slow, and we do not go over 100, most of the effects in that early area. You'll see the meta-analysis for this is one of the most extensive around, and yes, it produces a very nice 6.5% weight loss over and above placebo. So it's probably slightly better than some of our other drugs, but in combination with phentermine actually provides the best thing we've got. Using topiramate, you need to know its indications, its contraindications. Look it up. If you're using it for epilepsy and migraine, you'll understand it, but it is not something that you should use off-label without telling the patient and telling them the issues and problems, even providing written evidence of that. Weight loss with Saxenda. Now, I know none of you are using it, but it's a GLP-1 agonist. It's used for, does anyone heard of Victoza for diabetes management? It's exactly the same drug. Very effective at 3 milligrams for weight loss. You'll see the average weight loss in a general population is 8%. That's with the placebo, that's with the placebo. 6% in type 2 diabetes, and in obstructive sleep apnea, 5.7. Remember, people who are insulin resistant, often with diabetes, struggle to lose weight. So that's typical of what we see in across the board with all sorts of other studies. The general population do better than people with diabetes or who are very insulin resistant. We start low and go slow. 0.5 milligrams up to 3 milligrams. 3 milligrams is the maximum dose. Most of the side effects are GI side effects, and we can adapt the dose to the person. I've got people who are on 1.2 or 1.8. They don't have to have the 3, and because it's expensive, they can be maintained on a dose that suits them. This is a summary of the drugs from that review that Fong and I did, and you can go to that article in Australian Family Physician and update yourselves on these. Bariatric metabolic surgery. These are the common procedures done around the world. By far the most common today is the sleeve gastrectomy, the one in the middle. In Australia, it's about 70 to 80% of what's been done, and banding, adjustable banding and Roux-en-Y are done less commonly. There are differences in the weight outcomes. There's differences in the advantages and disadvantages of these procedures. There are differences in the nutritional requirements afterwards. So it's up to you to learn the key elements of these procedures so you can counsel your patients about them. Most importantly though, oh, by the way, they are all very safe. They're all done laparoscopically, and the risk, even of the more complex one, the Roux-en-Y gastric bypass, is very similar to having cholecystectomy. So we must be very clear that these are not dangerous procedures, and they're not things that should be kept as a last resort. I showed you this slide earlier of the sustained weight loss after the very low calorie diets, after the surgery, out at 20 years. The idea that these don't work is absolute rubbish, and I get told all the time, well, the patients lose weight and they put it on again. On average, they don't, and they're maintaining very useful weight loss over many years. And yes, these are facilitators. We can get people to change their way of thinking, change their approach to food, change their exercise patterns, and do so much better. They're enabling, very important. This is mortality after bariatric surgery. It reduces the risk of dying just by around 40 to 50%. Cardiovascular disease, 50% reduction. Deaths, 50% reduction. Cancer, 50% reduction, often occurring within a few years. In other words, it's stopping progression of cancer. Dramatic results. This is not fringe surgery, fringe stuff. This is some of the best evidence-based medicine you can provide. The indications for bariatric surgery are important. BMI over 40, BMI over 35 with comorbidities. If you've got type 2 diabetes and your BMI is over 40, bariatric metabolic surgery is recommended. if you don't tell the patient about this and then they develop kidney disease or blindness or peripheral neuropathy, they can sue you. And these are guidelines that are accepted globally. If you've got a BMI over 35 and diabetes is poorly controlled, then you also need to tell the patient about surgery. This is international guidance. We follow this in Australia, but who gets it? Hardly anyone. And so this is a problem. There are very few contraindications to surgery. People think there's a whole lot. There are very few. If you're concerned about a patient, send them to someone who cares, and they can decide whether they, and that'll be a very caring bariatric metabolic surgeon, or perhaps some of the doctors who work with them. But I think they will tell you whether there's an indication or contraindication. Don't you decide. So my conclusion is these tools work. That's why we should be using them. They are lifestyle enablers. They don't replace lifestyle, but they are needed. It's dysregulation of weight that's the problem. It's in the brain. It's related to the hypothalamus and hedonic centres, and they work together to make sure we struggle to lose weight. And if you're not using this whole range of tools, then you haven't started to think about how to treat people with significant, clinically significant obesity. Thank you.